Good day, viewers. We are the Group B3 from Martins NP. Today, we will present to you our case analysis entitled SIAD as a result of central nervous system ischemia. A 54-year-old female patient with no history of chronic diseases was admitted to the Department of Internal Medicine due to hyponatremia stated in the ambulatory test. The patient had been undergoing complex neurological diagnostics for the previous month in order to determine the underlying cause of her collapse, which was further accompanied by the occipital headaches as well as balance disorders. A head CT scan was performed during the patient's stay at the Department of Neurology and revealed two hypodense lesions indicating ischemic damage of the brain. The patient did not report any symptoms at the time of admission to the Department of Internal Medicine. The physical examination was unremarkable. Further laboratory data indicated an advanced hyponatremia with sodium levels of 121 to 122 millimole per liter. The blood morphology results and urinalysis, as well as potassium creatinine glucose transaminase (TSH), adrenocorticotropic hormone, and fasting cortisol concentrations were within normal ranges. Arterial blood analysis indicated low serum osmolality measured as 249 milliosmol per kilogram. Water. Normal ranges 270 to 300 moles milliosmol per kilogram water, whereas the urinary sodium excretion was unaltered at the level of 122 millimole per 24 hour. Normal 40 to 220 millimole per 24 hour. This is a standard specified by the central laboratory where the sample was analyzed. Ultrasound examination of the abdominal cavity and chest X-ray revealed no significant anomalies. In addition to the proper kidney, thyroid, and adrenal gland function, along with low plasma osmolality, the diagnosis of the SIAD was made. An abdominal CT was performed as a part of diagnostic measures taken to discover the underlying cause of SIAD syndrome and was found to be unremarkable. The treatment regimen included restriction in daily fluid supply to 1.5 liter as well as additional sodium chloride supplementation. This allowed for an increase in the plasma sodium concentration of 137 millimole per liter, together with normalization of the serum osmolality. So again, the title of our case analysis is Syndrome of Inappropriate Antidiuretic Hormone Secretion or SIADH as a result of central nervous system ischemia.
So first, let's discuss anatomy and physiology, SIAD caused by CNS ischemia. The endocrine system. Endocrine system plays a vital role in orchestrating cellular interactions, metabolism, growth, reproduction, aging, and response to adverse conditions. The endocrine system involves the release of chemical transmitter substances known as hormones. These substances regulate and integrate body functions by acting on local or distant target sites. Hormones are generally produced by the endocrine glands but may also be produced by specialized tissues such as those found in the GI system, the kidney, and white blood cells. The endocrine system has a unique relationship with the immune system and the nervous systems. Chemicals such as neurotransmitters, example epinephrine, released by the nervous system, can also function as hormones when needed. The immune system responds to the introduction of foreign agents by means of chemical messengers, such as cytokines, and is also subject to regulation by adrenal corticosteroid hormones. Next is glands of the endocrine system. The endocrine system is composed of the pituitary gland, thyroid gland, parathyroid glands, adrenal glands, pancreatic islets, ovaries, and testes. Most hormones secreted from endocrine glands are released directly into the bloodstream. However, exocrine glands such as sweat glands, secrete their products through ducts onto epithelial surfaces or into the GI tract. Next is function and regulation of hormones. Hormones help regulate organ function in concert with the nervous system. The rapid action by the nervous system is balanced by slower hormonal action. This dual regulatory system permits precise control of organ functions and response to changes within and outside the body. The endocrine glands are composed of secretory cells arranged in minute clusters known as acini. A rich blood supply provides a vehicle for the hormones produced by the endocrine glands to enter the bloodstream rapidly. The amount of circulating hormones depends on their unique function and the body's needs. In the healthy physiologic state, hormone concentration in the bloodstream is maintained at a relatively constant level. To prevent accumulation, these hormones must be inactivated continuously by a negative feedback system so that when the hormone concentration increases, further production of that hormone is inhibited. Conversely, when the hormone concentration decreases, the rate of production of that hormone increases. The pituitary gland is a small gland that sits in a bony hollow in the base of the skull, underneath the brain and behind the bridge of the nose. The pituitary gland is an important gland in the body, and the hormones it produces carry out varied tasks and regulate the hormone function of many other organs. Two main parts: the anterior pituitary gland and the posterior pituitary gland. The gland is attached to a part of the brain, the hypothalamus, that controls its activity. The anterior pituitary gland is connected to the brain by the short blood vessels. The posterior pituitary gland is actually a part of the brain, and it secretes hormones directly into the bloodstream under the command of the brain. Next is posterior pituitary gland. The important hormones secreted by the posterior lobe of the pituitary gland are vasopressin, also referred to as antidiuretic hormone, and oxytocin. These hormones are synthesized in the hypothalamus and travel from the hypothalamus to the posterior pituitary gland for storage. Vasopressin controls the excretion of water by the kidney. Its secretion is stimulated by an increase in the osmolality of the blood or by a decrease in blood pressure. Oxytocin secretion is stimulated during pregnancy and at childbirth. It facilitates milk ejection during lactation and increases the force of uterine contractions during labor and delivery.
So now let's discuss what is syndrome of inappropriate antidiuretic hormone secretion. It includes excessive ADH secretion from the pituitary gland even in the face of subnormal serum osmolality. Patients with SIADH cannot excrete a dilute urine, retain fluids, and develop a sodium deficiency known as delusional hyponatremia. SIADH is often of non-endocrine origin. For instance, the syndrome may occur in patients with bronchogenic carcinoma in which malignant lung cells synthesize and release ADH. SIADH has also occurred in patients with severe pneumonia, pneumothorax, and other disorders of the lungs, as well as malignant tumors that affect other organs, as according to Kaiser and Ho 2016 as well as Port 2015. Disorders of the central nervous system such as head injury, brain surgery or tumor, and infection are thought to produce SIADH by direct stimulation of the pituitary gland. Some medications such as vincristine oncovin, phenothiazines, tricyclic antidepressants, and thiazide diuretics and nicotine have been implicated in SIADH. They either directly stimulate the pituitary gland or increase the sensitivity of renal tubules to circulating ADH. The syndrome of inappropriate antidiuretic hormone secretion or SIADH is an etiologically diverse pathological condition resulting from the elevation in both ectopic and autonomic secretion of the antidiuretic hormone or ADH by neoplastic tissue. excessive stimulation of the hypothalamic pituitary axis, such as in pulmonary diseases, central nervous system, abnormalities, endocrine glands dysfunction, or due to the use of some medications, intensification of renal ADH action by certain medications, and action of substances chemically related to vasopressin. The clinical characteristics of the syndrome are comprised of the presence of inadequately concentrated urine, hyponatremia, and hypoosmolar blood serum, as well as weight gain. Sodium disturbances are common in patients with brain injury because of the major role that the central nervous system plays in the regulation of sodium and water homeostasis. In addition, treatment of the injured brain can itself disturb regulation of sodium and water. Sodium disturbances can lead to serious complications and adverse outcomes, including death. Sodium is the major extracellular cation and one of the most important osmotically active solutes. The extracellular to intracellular fluid sodium concentration gradient is maintained by the sodium-potassium ATPase pump, and total body sodium is controlled by renal excretion. Sodium is freely filtered at the glomerulus, and the majority is reabsorbed at the proximal tubule, under the control of sympathetic nerves and atrial or ANP and brain or BNP natriuretic peptides. The latter cause natriuresis by inhibition of sodium transport in the medullary collecting duct by increasing glomerular filtration rate and by inhibiting renin and aldosterone release.